Patient with asthma usually have chronic cough, so they will have cough at least more than 2 weeks. Okay, that just the simple trigger, simple history that you might want to probe further on asthma history. Okay, how to diagnose asthma? So basically, when you take history, if patient presented with cough or rapid breathing, so on top of your usual cough history, the character, the timing and all that, plus the rapid breathing, there are few more histories that I would like to hear, or any medical officer or pediatrician would like to hear, to help them diagnose a patient got asthma or possible of asthma later on. Okay, so when you talk about patient having cough, asthma cough usually is dry cough, alright, but no specific characters or anything lah. If pertussis, there is a prolonged bouts of cough with facial congestion and sometimes with apnea as well. But for asthma, there is no specific cough character. Also like croup, if patient has croup, the cough will be barking cough plus features of hoarseness of voice or stridor. Okay, but for asthma, sometimes the cough also may come with noisy breathing. If patient have wheezing sound or noisy breathing, it might be asthma. But that is not the most important thing. The most important thing, we want to know patient has history of interval symptoms. Interval symptom is the period where patient is well, patient has no fever, no runny nose, but there is symptoms of coughing, specific times, example night cough, or specific cough triggered by exercise, specific cough triggered by cold drinks, cold environment, specific triggers including laughing or certain things as well, like eating chocolate or eating soda drinks, sugars and all that. Okay, so on top of it, you want to know about history of nebulization. Is this patient come with rapid breathing? They always will go to the hospitals, emergencies visits, or general clinics, and we want to know the history of nebulization, whether they were given naps or not. So the nap, we want to know a bit more about the nap. Is it given because of rapid breathing plus a noisy breathing hurt, or is it because of the phlegm? They just want to loosen up the phlegm a little bit. That might be another reason for giving the nap. Okay, so the frequency of nap for the past 6 months, let's say, or 1 year, if 3 to 4 times nebulization with specific history of upper tract infection causing rapid breathing. Okay, so more frequent nap, the likelihood of hyperactive airway or asthma is more likely to be so. Okay, on top of it, we want to know whether specific triggers like other history, strong family history of asthma in the family, eczema. Also on top of it, patient has symptom of allergic rhinitis. Okay, and then this is all this strong predictive index for asthma lah. Okay, the asthma predictive index or API lah, like as mentioned in the PRITS protocol. Okay, so another factors you want to know whether patient have carpets at home, pets, cats especially. And then more important thing is anyone smoking at home lah, whether it's cigarette smoke or even vaping smoke. Okay, if patient have many interval symptoms like frequent night cough, frequent exercise induced cough, or cold induced cough, specifically cold drinks, cold weather, so these are possible history that indicates that patient might have asthma. Okay, so it is a clinical diagnosis by clinical history and clinical examination lah. On examination, you might want to look for signs of chronicities. There will be dry skin or eczema, patches at the flexors, the neck, the bodies. There is chronicity in the nasaturbinate, where the nasaturbinate is enlarged, and pale nasomucosa. On the chest, you might see Harrison sulcus, and then you might see hyperinflated chest or barrel chest. Hyperinflated chest and barrel chest. On top of it is the Harrison sulcus is due to the protruding of your diaphragm forwards and pushing up the ribs, so cause a curvature anteriorly, so that give rise to your Harrison sulcus. Okay, on the lung finding, there should be reduced air entry, prolonged expiratory phase, and could be generalized bronchi. Alright, might come with crepitation as well if the asthma is triggered by the pneumonia. On the chest X-ray, you might see the hyperinflated chest, and then tubular shape of the heart, because the lung is so hyperinflated, causing the heart to be smaller. Okay, because of the hyperinflated chest. Right, those are some features of asthma. How to diagnose asthma or give clue to you that this patient might have asthma. Okay, so that investigation and all that is not very important in diagnosing asthma. But if you do certain thing, you might want to do peak flow expiratory meter, pre-nap and post-nap. Pre-nap, you take one peak flow, and then post-nap you do another one. If there is 20% rises in peak flow reading, so that indicates reversible of the airway bronchospasms. Alright, but you can only do it in the children that are big enough to do and able to do it properly. Okay, so the toddlers, the preschools might not able to do it properly lah, but the school going age or teenagers, they might be able to do it properly. So you just have to teach them and assess. Alright, but the problem when you take history regarding the interval symptoms, you might find parents report that patient won't have any interval symptoms, but when you examine them, they will have a lot of signs of chronicity like Harrison sulcus, hyperinflated chest. So why so much difference when you examine? Why the history is not there? So this thing can happen because sometimes parents don't really notice the cough because they are not aware of it. The night cough, the cold-induced cough, then even the exercise-induced cough, because they might not notice it because they not aware of it. If you are in the situation where you have these difficulties for getting the interval symptoms, so you might want to follow them up, give them a follow-up appointment. Then what they do at home, you advise them to do cough diary. So you advise parents to monitor the cough, specifically when child is running around playing, so whether they are stopped coughing, started to cough or not lah when they started playing, or the symptom of coughing when they drink certain things like drinks with flavored drink, drinks cold drinks, even hot drink, and whether they're coughing during the morning bath or during rainy weathers or even at night, or when patient in very cold aircon or conditioned environment. Okay, those are specific things. So when you provide them the cough diary, they will just stick and then bring them to the appointment, clinic appointment, and you can review to help you diagnose patient got asthma or not. Alright, okay, so the advice is very important to help to you diagnose asthma. So if patient have many exacerbation per year, like 3 to 4 times per year, rapid breathing suspected with upper tract infection, so patient might be having an asthma, but it could be some other problem. So the age is very important factor here. So the age more than 5 years old, if patient can be rapid breathing and you heard rhonchi, wheezing and all that, is asthma until proven otherwise. But less than 5 year old, it could still be asthma, or it could be some preschool with features of asthma as well, because the treatment is the same. Alright, so the age is very important factors, but you may have to take into account some other diagnosis as well, including your preschool wheeze, or including your bronchiolitis or episodic viral wheeze. Alright, okay, but what are the features that might not be an asthma, even though you present with wheezing or rapid breathing recurrent exacerbation in a year. So if patient have failure to thrive and patient have clubbing and is some focal sign of cardiovascular sign and symptom, that not might be asthma. So it's very important to check your growth chart and then plot your growth chart properly. If patient have failure to thrive, it might be something else. It could be some chronic suppurative lung disease or something else. If patient have very bad history, neonatal period, and or onset is very very early, including neonatal onsets or infantile onset, we might have to rule out other causes as well. So it could be a lot of things related to the upper airway or even lower airway. Okay, it could be tracheoesophageal fistula, it could be some other problem like cystic fibrosis and all that. So yeah, so be aware of certain features as well. If patient already started on MDIs like fluticasone and all that, but patient have very poor response to it, even poor response to salbutamol, that's another triggers, that's another clue that might tell you this might not be asthma. So have to be aware of it as well. Okay.